some people do dowsing. I think there's a lot of different ways you can try to, what you're trying to do is cut through all the confusion and positionalities to find out what your true self really needs. And that's, I think, ultimately, that's often my goal, is to try to find out what my true self really needs. And I believe that there is absolute truth. It's out there, but sometimes we have trouble getting to it, the absolute truth.
And there's also bias to self-muscle testing, right? If you think you need something, it's probably going to show up for you. So you have to be very unattached to the outcome.
I've done that for if I was trying to make an offer on something. I bought another motorcycle this last summer, and I was the guy was asking, and on my way to go look at it, I was self-testing how it was an offer, and then I'd ask myself, will he take it? No. Will he take this much? Yes. And it ended up being absolutely spot on. But did I know that anyway? Well, sure. But the muscle testing just kind of gave me a feat of positive loop of reinforcement. So you won't be tested on that. We're going to talk about, okay, so I do want to try to get to the to doing the muscle tests that you found on posture, and I think that's your main goals this afternoon. But we're going to talk about rebound challenge, like vertebral challenge. Now, there's two ways to challenge a vertebrae. You can challenge it statically. You can challenge it dynamically, meaning you rebound it, you spring it, let it go. Two ways to, but that's different than TL. Very often, how you determine where you're going to start challenging is TL. Also, palpation, tenderness, history. You can tell a lot with motion palpation and static palpation if the vertebrae is, if it's sitting properly, if it's moving properly. But the TL will really verify that. And then you go to challenge. So you don't go from zero to challenge. You go from zero to, oh, there's something there. And then you start looking at it, looking at the vertebrae with your hands. And this one's really tender. So we'll challenge that one first. And that's how you go about it. It's not anymore. Don't overthink it, I guess. But don't do challenge before you do TL. Don't just go chasing in the dark. That's what I think I'm trying to say. So the intrinsic muscles of the spine, the muscles whose sole purpose for being there are to manage the position of the vertebrae relative to one another. These muscles are not intended to create big, powerful movements in the body. They're devoted to the vertebrae, making sure they're staying in their track. And these are the muscles that get, when we have a subluxation or fixation, when we have a lesion in the spine, these are the muscles that are central to that problem. You can have all kinds of back pain. You can have trigger points, out in the thicker muscles from trauma. Doesn't necessarily mean you have a subluxation. You may end up with one, but these are bigger, thicker muscles. They're not quite as neurologically sensitive as these guys here. And so what happens is these guys here are like guy wires. I've got several misprint slides here ahead of me. I'm going to skip through those, but these are the intrinsic muscles that we're dealing with when we do a rebound challenge. Obviously, if you stretch this spinous process this way, you're going to impact all these little muscles. Some are going to get stretched. If they're in lesion, or if maybe the joint capsules, the set capsules are in lesion, then you're going to get blood of nociception, and you're going to get a weak muscle. You're going to get a positive muscle change. Likewise, if you push this, the vertebrae it really wants to be released over this way, and it really needs to be corrected in this direction. You push that direction, and that will not weaken a strong indicator muscle, but it may strengthen a weak starting muscle. That doesn't confuse you. If you push, and let go, and it's in lesion this way, it's going to bounce further into lesion. Then you get, what you're looking for is that flood of nociception, disrupting the reflex dynamic between central nervous system and brain, between cord and muscle, I should say. Between cord and muscle. A lot of the neurologic activity that goes on with this is managed, much of it at the cord level and the lower brainstem level, cerebellum. So let's go ahead. These are some other muscle. I don't know what happened here. There's something missing here, and this slide is under construction, I think. This, you guys are familiar with this concept, right? Tensegrity. Who's the famous architect that made this famous? Was it?
I don't know, but I think we only learned it in AKA. I don't think I learned it in school.
Anyway, this is what makes the world work. This kind of design, structural design. Tensegrity is when you have two components, one resists compression and one resists tension. And you put them in opposition to one another and you can create a light, flexible space. So a tent is a very simple example of that. You got tent poles and then you have the tent sheets and lines which resist tension. The poles resist compression and the net result is a space. You've created space. This is how our body is constructed. Our vertebrae are as much suspended as they are stacked. And the intrinsic muscles are the guy wires. They're these guys here that kind of keep it together, but also they're able to shorten. So they're able to create movement. This model here can't create, it can only, like if you can push it all different. I have a couple of these in my office. I used to bring them when I teach, but they take up too much space. But I use it to show patients, and they get a kick out of it. And you can use these models. You can slide it so that it shows how you've got short muscle and long muscle. You'll see how it contorts the whole thing. Oh yeah. So it's a fun thing to use for demonstration. You can get these through the Anatomy Trains outfit. You guys are familiar with him, Thomas Meyer, Anatomy Trains. Check out Anatomy. Thomas Meyer, he's got a couple of books out. But he's also not afraid to sell things. So he's got these for sale. Anyway, tensegrity, that's how you want to think when you're thinking about how these vertebrae are being managed in space. Our cells, the cytoskeleton of our cells, it works in a similar way. We've got stiff areas that resist the tension of the cell wall. Otherwise, the cells would be collapsing in on one another. So, we're going to try this. I'm going to do a demo. Okay, here we go. 2 ways to challenge rebound and static. I'm going to show you both. Anything? No, I do do we have paper here? Yeah. My demonstratee. This other thing. Yeah, there we go. Okay, so why don't you guys come forth, gather around. We found something here. Now it's hard for her to tee out herself in this position, right? So, but can you touch here at all without straining your shoulder?
No. I have very limited range of motion. But
yeah, that's probably not. Yeah, that's not. Yeah, we're just going to have to. I'm going to. We know this. Dr. TL'd it, and there is something here. So, let's pretend I found a positive muscle change with her TLing it. Hold there. I'm just going to give that a little tap. So that's not a TL, it's just kind of means the skin receptors are kind of sensitized. So, yeah, so see how actually the response is actually a little bit great. It's right there. That's it. So is this tender?
Yes.
Is this tender?
Yes. I don't know if it's the same or
More.
That's definitely worse. Never
Okay.
mind. I lied.
Here? Okay, so that sometimes like a whole row of them will be tender, but or whole grouping, but there's this is definitely it. So I'm going to palpate on either side. And while I hold that spinous, I press on the lateral mass. Kind of, I don't want to be out on the ribs. I'm right on the TPs, not lateral mass, TPs. And looking for spring, and there's less spring there. Okay, so I'm going to challenge, I got a strong indicator muscle. So first I'm going to challenge it this way. I'm not sure which way. It may need to go this way. So hold there. Okay. So I'm going to use my pisiform and just kind of gently rock it. Did that move? Sometimes they actually adjust when you're doing this. And hold. Yeah, so that was, got lucky there. And I'm going to go back the other way. Okay. No change. Okay. So this is all rebound. Push, 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 let go. Weakness. Push, 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 let go. No weakness. So what would that tell us? This is where it's happiest.
What's happiest?
This is where it's happiest. If I push this way towards lesion, what we're thinking is lesion, let go, no change. So it's
So
happy
a
there.
rebound is gonna go further into lesion if it causes weakness.
Yeah.
So he's pushing this one this way and it's rebounding back and she's staying strong.
So
And
now,
now he's pushing this way and it's gonna, when he lets go, it's gonna rebound this way.
right.
So it's into lesion. That means it's this, it's toward,
Yeah.
So it's leaning this way, which is causing weakness, but it wants to be this way.
Okay. So I'm going to go push, push, push.
Inverse.
Okay.
Inverse.
Yeah.
Well, I guarantee you, I promised her we cleared up where she had to leave and she leaves at 2. So we'll make sure
We'll
everybody.
go over this more.
Yeah.
more.
So just watch me. Push, 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 let go, weak muscle.
Push it this way,
Third or
it's
fourth time.
rebounding further into lesion this way.
So I want my direction of correction is this way. If I was gonna,
Is that left or right?
it's right to left. It's this way.
You're gonna adjust it that way.
I'm going to adjust
It
it
wants
this
to be
way.
that way.
Okay.
Okay. Now, before I adjust it, I could do a static challenge to back that up. Rebound challenge is a little more accurate when it comes to adjusting. So I push this way statically towards the way I think I'm going to adjust it. No problem. It's happy with that. I push this way, not happy. So it's verified both ways. Now, sometimes they'll give you some crazy results, and usually it's because maybe you're not careful enough with your vector or your contact. So this is just an incredibly valuable tool. If you know, like any tool, if you use the. She's also got a rib right here. And she also has some stuff going, okay, if I share your
Oh, yeah.
ailments, she's got some stuff going on in her elbow. It's been popping, and we adjusted her wrist and a little bit elbow. But yeah, and when you were walking, what did we see? What did we remember?
Oh, heck if I remember.
Do you remember what you were being told?
Then I walked like a toddler and then I had springy feet. That's all I remember.
Wow.
I took the good stuff.
Yeah. Any of you guys remember her gait? Do you remember Dr. Whitney?
Mhm.
Anything
Oh,
specific?
Her arm was. Did anyone say that to me? And I just didn't hear.
Arms were kind of this, but yeah.
Oh, okay.
Well, let's adjust this. Now I could do it kind of old school chiropractic, like prone, or which is, or I can do it supine. What would you like to see? Preference.
Fanciest way.
No problems.
The what fanciest way?
Give us
This
a
is
go.
the probably, this is kind of the old school, kind of Gonstead style chiropractic. It's definitely you have a chance of being more accurate with this, but these only, I don't like these if the patient's spine is very flat. Now her spine, I think, will lend itself. You're doing okay?
Mhm.
So I build tension. I take time. You see people going whack, whack. I come up and I just feel my way into it. I'm kind of getting to know what's really going on there. And sometimes I'll actually shift my vector. Now I've got pressure there and I'm going to go on the TP of the other side. This is more like a fixation style hand position, but the classic subluxation is more like that.
And what was your vector?
Right there. Just right there. Breathe in deep and let it go. Now, I may or may not adjust it. I'm just going to kind of load and see where I go. I'll breathe in again and let it go. And now I feel this rib. I'm going to give that a little traction. Good. You okay? One more time. Breathe in and let it go. And I'm kind of leaning there. Okay?
Oh, yeah. Oh, fine. That felt good.
Good. Actually, two things moved there. The vertebrae moved and this rib moved too. So there's a couple of little releases.
It felt like way more than that. I don't
Well, maybe it's a whole chorus in there. So I'm going to go back and I'm going to rebound challenge again, right? Same thing I did to find it. Release, strong indicator muscle. Nothing. I'm going to be super thorough and I'm going to push it back towards what we thought was lesion before. I'm going to hold it there, static challenge. Nothing. So I'm happy. Now I would probably, right in here is a little bit, because this is kind of this way, this here is a little bit anterior. And I'll show you how to hold there. Now I'm going to push straight forward. That's the anterior. That's a direct static challenge. It's hard. You can do a dynamic challenge for anteriors or straight on, but I would really recommend doing static challenge when you're challenging like P to A. Static challenge, weak. So I'm going to do lay on your back for me. I'm going to do a kind of a.
With that static challenge that you're doing, you're pushing it more into lesion because it is interior.
Yes. Static challenge. When you get a positive response with a static challenge, strong indicator muscle, positive response means that you've gone into lesion and you're getting the muscle response. You could, I think, yeah, learn them both because they're both helpful. And a lot of times, most of the time I do both on patients, and I'm fast, so I can do them just bang, bang. And then I really know before I blast them that I'm really going in the right direction. Before I did AK, I did lots of adjusting, but I had a lot more problems. I had a lot more people come back sore, a lot more problems with adjusting. Over the years with AK, it's allowed me to get precise enough, hardly ever have a negative response from a patient. And I'm also really picky about how I adjust them. There's no one size fits all. You okay if we adjust that? So that was T3. And we're going to be adjusting T4 on T5. In case you want to chart this. Now, normally I have a little cushion and I'll put it, men or women, I put it right here to give them a little extra something. Go ahead and lift your head. And breathe in deep. And let your breath come out. And let it relax. Good. So I want to feel all of her weight. I've got my hand, if you guys want to come around, I've got my hand under T4. And my lower hand is on the vertebrae. I'm just kind of guiding her to breathe in deep and breathe out. Good. I can tell she's kind of released there.
That is very precise though.
It is, yeah.
Jeez.
You think?
Yeah, I feel like I actually breathe easier.
I know.
I hold my breath a lot.
Why?
I don't know, I feel like I can't breathe.
We don't get very many hobbies around here, holding our breath on it.
True, summertime, like stay inside and hold your breath.
Mhm.
Now stand for a second, please. Hold there, push down. Was that was week before? Yeah. Somebody else we did this on that was had an injury already. Right there. Push. And then go the other way. It's okay. You mind if we adjust that real quick? So I'm gonna adjust the neck and then what you guys are all gonna do this, okay? You're gonna TL. You're gonna try to remember the postural distortions that you had. Try to find a muscle that correlates to that. High shoulder, go to the left. And if you find a weak one, you're gonna TL near the nerve supply and see if that muscle turns on. And if that happens, then we'll go to challenge. We can help you work through it, but we're all going to challenge vertebrae. But lay on your back. I think we have enough time, right? No, a couple of you have to leave early, but apparently you've got something.
Now we've got 3 hours.
Pass the exam. So I'm going to use the pectoralis major to, it's a very convenient muscle to use as an indicator muscle. I prefer it to the old fashioned anterior deltoid that was originally taught here for health in the early AK stuff. I think that's not a bad muscle. Leibowitz uses this.
Yeah, it depends on who you look, Everett, so. Most people, I think, like the individual one, and then you have other people who do a mixed muscle that takes out the organ component. So that's sometimes the argument is like, because this has a couple different, you take away the lung component, you take away the stomach component, and now you just have a muscle test.
It's a good argument. So what I'm doing is I'm challenging P to A on her left C6. No change. I'm going to move up a little bit. I'm going to palpate. I'm going to spring P to A on her C5.
That's the rebound challenge.
Rebound. Press, 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 release. That's positive. So that means it's posterior on that side. I'm going to go over this side because I don't think that's the main problem. A lot of times with C5, C6, one side goes posterior and the other side goes anterior. See, that's not showing posterior. I'm challenging P to A. No change. Now, if I statically challenge anterior, sometimes this is where static is going to be a better test. I get a weakness. We get a positive change. So her vertebrae is like this, and it's not happy like that. So if I push it further, it's kind of okay, but if I push it further like that, it's not happy. Her nervous system's not happy. So the adjustment's going to be this way. Now, this is out, and I'm always taking you guys out in the weeds, but this is going to be how I adjust the anterior vertebrae. You guys get much training in anterior cervicals and there's OCPA stuff. Most of my chiropractic training was, fortunately, I had a couple of instructors that were good with anterior arteries, but so it doesn't really matter. It's just what you call it. She's got a posterior artery on the left, but if I don't support the right side of the vertebrae, because that's really where the neurological stuff is showing up, is on the right side. So I've got my thenar against her C5 on the left, pushing P to A. I've literally am kind of pinching the lateral mass of her C5 here. I'm pulling it slightly up to give it space, and I'm kind of twisting it into position right here, okay? And just let that settle.
That's the third time anyone's ever touched my neck, so I didn't die.
Really?
Yeah.
Actually, I actually was okay.
Oh, yeah, no, I trust you.
Third time?
Yeah, the first time I started having an anxiety attack, I wheezed and they were like, what's wrong with you? Then someone else, I liked him too, it was Kevin, and I couldn't say no to him, so I let him. And I had blotches all over me afterwards. And then I just let someone 2 weeks ago Stopa for the first time.
Do what?
Let Dr. Stopa do it for the first time 2 weeks ago, because I was about to vomit from the headache. So,
Were you okay?
oh yeah, I didn't die.
No.
So I've gotten better with age.
Yeah. That moved beautiful. I didn't feel like something's been moved
Yeah, it doesn't
that
feel,
way.
probably not, because I don't think he does the
Yeah.
interior part.
Okay, so let's re-challenge. So any questions? Pretty basic move, but that's the way I've done them for years now. I used to do the old diversified thing, but I kind of, I just don't do it that way anymore. I do it more. I don't know what you, this is kind of like the neuro guys. The neuro guys are into this coupled adjusting, which is pretty amazing, where they try to move both vertebrae out of lesion at the same time, thinking that it's going to result in a better, reprogramming. So I'm not a neuro guy, but that's now P to A, no problem. P to A, no problem. Static challenge A, anterior, no problem. We'll just static challenge here. So that there's negative challenge. There was positive challenge, now there's negative challenge.
Also significantly less tender.
Good. Good. And you'll get ready to get up. Wait. So push down. That was weak in the clear when we first started, right? Now let's just crowd that vertebrae a little bit. That accentuates an anteriority if you haven't looked down. Sure we're not missing anything. I only see people like once a month. So I really don't want them, I want them to last a month. So a lot of times I really, I'm happy with that. Yeah, hope you are.
That's good. So far.
Go walk, you don't have to leave yet, so go walk around and just kind of try it out. Go clear out in the hallway, walk it in, play it in. Okay. No, she just collapsed, unconscious, great.
Yeah, she's like, yeah, my neck is.
I was never here. Not funny, really. Not funny.
Only. Because that's not what
Is that-
it is said it's only funny because that's not what happened.
Yeah. Is she okay?
Yeah, it was.
She just slammed the door.
And like.
You okay?
Everything's fine.
You said you don't walk by with us.
Oh, good. Look forward. Let me just step back. Over. I mean,
Yeah.
There's other stuff probably, but this was big. Soft. Cool. Yeah. Now, do you understand challenge? Because you asked me, said,
A little bit, but I also was like, you were like, go this way and this way. I'm like, I think I know what he's saying because I was face down. So I was like,
okay, somebody else, let me do somebody else. We'll try.
you want one of us so everybody can see it?
Sure. You understand, John.
I, so.
Hi.
Been a little while.
Yeah. So, you got anything? I mean, you were just getting some adjusting over there.
I probably have some throughout stuff.
Okay. You want to sit here facing that way?
Certainly.
You probably have breaths and stuff.
I mean, sure I do.
So we'll use the deltoid. It's super convenient. It's once again, it's kind of hard to TL, have the patient TL with back. Ooh, look at that. Now I'm literally, okay, I'm gonna go much lighter. I'm doing, yeah. So it's right there. Now watch this. No, that doesn't do it. No, I gotta touch it. Yeah, sometimes they'll be so out that you can literally, yeah. Now we go down here. Yeah, look at that. Oh, yeah, so if I was gonna be real esoteric, I could say, okay, there's a problem here and here and here. But interestingly enough, she weakens there. If I touch her back, she doesn't really weaken. Isn't that interesting? I go just a little lower, hold. There she does. So, yeah, so I'm not really on it. So there, right there. Okay, so we've got 3 potential areas that could be in lesion. So, okay, laying face down, it's probably just some new. What's that?
It's probably the problem with my thing.
Okay, there.
It's that one.
So now that you guys have seen this a couple times, so what would I do next?
Fine. Good muscle.
The rebound.
That's
Before I do that, what would I do? I think you,
kind of a strong muscle.
strong indicator muscle, SIM. You'll see it written, SIM. Strong, SIM, strong indicator muscle. To do what?
Rebound.
Rebound challenge. What if I want to static challenge?
Then you say
That
do
too.
the rebound first.
We'll see.
Okay.
That doesn't matter.
Oh, okay.
But what matters is that you can zero in on which vertebrae. And I'll end up doing both. So we're just gonna do static challenge. I'm gonna evaluate this area with, if this muscle's strong, hold there for me. And so first I'm going to go in and I'm gonna statically challenge L4 from right to left. I'm going to statically challenge from left to right. There it is. Okay. Now, so which way would I correct it? This way. The way that it challenged and didn't cause a weakness. Right? Everybody got that, right? Okay. Now, I think it needs to go, see, hold there. I think it needs to go this way. So I'm going to challenge it this way. 1, 2, 3, let off. And I get a weakness again. That was a rebound challenge. Same, and think I need to go this way, then I let it go. It bounces further into lead. Dr. Whitney was saying. And I got a flood of nociception, and it would, any strong indicator muscle would weaken with that. You can pick any one you want. Pull in. Piriformis, that feels really good. Rebound. 1, 2, 3. There you go. Static, pushing into lesion. Rebound. So that makes everybody get that. So which way would I adjust it? This way. Would you land your right side? Is that okay?
Yep.
Okay. Yes. Right side down. You had this adjusted recently? Okay. Here's the vertebra. And I'm going to get a nice capture here. I'm over her ribs, so I don't want to push too hard. I've injured a few ribs over the years. I'm going to be kind of, and I'm going to bring her towards me. You guys can gather around if you want. That's being a teacher here. So I'm on the vertebrae, and I can either pull it this way. We know it needs to go this way. Just hold it by the spinous, or I can come in here with my feet on. I'm gonna pull it by the spinous. I like the spinous because I like being able to feel better if it moves. Okay, breathe in deep, breathe out. Always make sure you still have them. They're still, release one more time, breathe in, breathe out. So I've been holding her here and I just come in like that. Okay? Okay. You sure?
Yeah.
Okay. Thank you, Sarah. Okay, so we had a TL. I mean, a positive TL from examiner TL in there before. Remember, we were right here? Nothing. 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 No positive TL. That's kind of how it works. Now I could come up here, still got something there. But maybe we should save that. We might just save that.
Sure.
We need another demo. Thank you. Now, anybody not have this wired? Won't proceed until I know everybody's got it. Does everybody want to do it? So-
I think practicing helps.
Yeah, practice makes, perfect practice makes. So, when you team up, the person that's the patient, tell the doc what you had on static posture and on gait. Hope you remember. And then pick a muscle to test. It might be weak. Let's do that first. And then do that first. Pair up, exchange data, and get ready to test them out. And if you don't know which muscle, ask for Dr. Whitney.
Use the chart if you
Or
don't
use the
know
chart.
also the final level.